Age-related macular degeneration, referred to as AMD, is one of the highest causes of visual impairment for the elderly Western population. Owen et al. Estimated that there would be 679,000 cases of late-stage AMD by the year 2020 in the UK, and increased by 71,000 each subsequent year. AMD has been characterized into different stages and types. Early AMD presents mild RPE abnormalities, or small drusen and a few intermediate drusen. In intermediate AMD, signs of multiple intermediate drusen and large drusen, as well as geographical atrophy, may also be seen at this stage. Advanced AMD is categorized by one or several of the following: geographical atrophy of the retinal pigmented epithelium, known as the RPE, involving the fovea and neovascular maculopathy. If the presence of neovascularization is present, then it is subcategorized into wet AMD. Without, it is known as dry AMD. The eyesight remains relatively unaffected in the earlier stages. However, in the later stages, when the fovea is affected and/or neovascularization occurs, then vision is noticeably reduced. In recent years, treatment for wet AMD has improved due to the introduction of intravitreal injections containing antivascular endothelial growth factor, known as anti-VEGF. Drug examples being ranibizumab and aflibercept. Rosenfeld, 2006, found that 0.5 mg of ranibizumab administered via intravitreal injections to wet AMD patients for 2 years prevented further sight loss, and for 33% of the participants, visual acuity improved by 15 or more letters. Loss of vision by drusen or geographical atrophy can equally be sight-reducing and is not as easily treatable. Current methods focus on management, diet, lifestyle changes, and prevention. The AREDS 2001 study has shown that taking antioxidants and zinc can reduce progression of intermediate or advanced AMD stages for 5 years by 25%. AMD has been linked to have an increased risk if the patient smokes and/or has a higher than average BMI. Healthcare professionals also monitor for wet AMD signs and promote eating a diet rich in leafy green vegetables and oily fish. A Mediterranean diet rich in fruit, nuts, and vegetables, alongside regular exercise, has been linked to preventing AMD development. Several other disease progression preventions are being explored, such as gene therapy, cell-based therapies, inhibitors of the complement cascade, and neuroprotective agents, as well as others. Therefore, possessing a sensitive test with good repeatability to detect progression in AMD will become a useful tool as our understanding and monitoring of the disease continues. The Early Treatment Diabetic Retinopathy Study Chart, also known as the ETDRS chart, is the current gold standard for testing AMD, modified from the Bailey-Lovie chart in 1982 as a result from the recommendations of the National Research Council, Committee on Vision of the National Academy of Sciences, Working Group 39, and Dr. Rick Ferris, used in the Early Treatment Diabetic Retinopathy Study. Its format is 5 letters per line from top to bottom, progresses in 0.10 logMAR steps, uses Sloan letter optotypes C, D, H, K, N, O, R, S, V, Z, and arranged so each line has an average intermediate difficulty. Testing distance is 4 meters. Scoring is summed by every letter correctly identified, which is known as by-letter scoring. Thus, 35 letters correctly identified equates to 1.00 logMAR, and 85 letters read equals 0.00 logMAR. The ETDRS chart has been shown to have significantly better test-retest variability, known as TVR, compared to Snellen charts for both normal patients and those with AMD pathology. However, test-retest values for the ETDRS chart range between 9 to 14, as seen in multiple studies. This would suggest that a change in VA needs to be around 2 to 3 lines for diseased foveas to be considered a result of the pathology. 2 to 3 lines of variation is a sizable amount, and due to better treatment options for AMD, A chart with better sensitivity and a smaller TRV would prove a useful tool in monitoring the progression of the pathology. The Moorfields Acuity chart, abbreviated to the MAC, was originally created to improve the test-retest variability of the currently used high-contrast design visual acuity charts. The MAC chart is formatted with many of the same properties as the ETDRS chart. However, the MAC's letter set is printed in a pseudo-high-pass design. The letters are of a black core with a white outline and presented on a grey background to which they have an equal mean luminance. This filters out the low spatial frequencies and only allows the high spatial frequencies to pass through. As a result of this, the recognition and detection thresholds become almost identical due to the mean luminance of the letter and the background being equal. This makes the letters appear to vanish when reaching the acuity threshold under foveal viewing conditions in normal subjects. This is contrary to the conventional test charts, as the high contrast from the black letters on the white background results in separate values for recognition and detection thresholds. Professor Roger Anderson, a co-inventor of the Moorfields visual acuity chart, is here to explain what they found when comparing the MAC chart with conventional letter charts on patients with AMD.
When we did preliminary experiments with this on patients with macular degeneration, we found not only was it more repeatable, which was very good, but it was also much more sensitive to early macular degeneration. And we didn't exactly understand why that was, and we did a little bit of modelling to try to understand why that was. And it seems that when the cells in the retina become sick and die and drop out, and the letter becomes undersampled, that undersampling makes the letter less recognizable at an earlier stage with these letters. So that's why we think it seems to be a bit more sensitive to early macular degeneration, as well as being more repeatable. And the importance of all this is not only that you can detect macular degeneration at an earlier stage, but you can also detect it more reliably with more confidence. You don't have to find two lines of difference in order to be confident that there is a change in visual acuity. You can be confident with a smaller change in visual acuity.
The importance for earlier detection due to disease is highlighted by Kleen et al. In 1995, who found that early AMD lesions only resulted in a loss of 2 letters or less when comparing with eyes without AMD lesions. This suggests that AMD loss is measurable using the ETDRS chart when the disease progresses further and affects the fovea to a greater extent. The ability to detect these small changes in visual acuity could alter the outcome of having treatment, especially when one of the criteria is a loss of 5 letters or more. Therefore, as the instances of AMD cases increases, and so does the use of treatment, it is becoming more vital to have a highly specific and sensitive test to monitor a range of AMD stages and measure progression, which is easy to perform.